Thank you, everyone, for joining us today for this webinar from encephalitis411.org. We appreciate your participation and hope you learned some things along the way. With me today, I have two of our board members, Dr. Karen Bloch and Dr. Carol Glaser. I'm going to just let Karen and Carol introduce themselves, and then we'll move forward. Karen, I'll start with you.
Thank you, Becky. Hi, I'm Karen Bloch. I'm an ID physician. I treat mostly adult patients. My interest in encephalitis dates back over a decade when I was involved in a CDC study trying to identify causes called the Tennessee Unexplained Encephalitis Surveillance Study.
Thank you, Karen. Carol?
Hi, this is Carol Glaser. I'm a pediatric infectious disease physician, and like Karen, I have a very strong interest in encephalitis and worked on the California Encephalitis Project for over 15 years.
Great, thank you, Carol. Together, these doctors represent hundreds, if not a couple thousand cases of encephalitis that they have been part of over the years, and we certainly appreciate the knowledge that they bring to this topic. It's one that it's a rare enough disorder that people don't hear about it very often, although it has can also have lifetime consequences. It's something that once you are impacted, there's a lot of unknowns and ifs. So today I think will be very educational as we explore through the minds of people that have seen this many times and have been actively involved in research. I am Becky Dennis. I'm the board president of Encephalitis 411. I myself am a survivor. Have been lucky enough to have a pretty strong recovery, one that led me to also document my story in a book called Brain Wreck. So anyway, thank you again for joining. What we're going to be talking about today is essentially what is encephalitis. First, just a little bit about Encephalitis 411. Our mission simply is to improve the quality of life for those impacted by encephalitis. That's a pretty big statement. When we say it, we mean not just the survivors themselves, but the caregivers that are often left in a new state of life where they are in a role that they didn't predict, where they are learning not just about the illness, but also trying to take care of themselves and their loved one. It's also for clinicians. There's a lot of questions because of how rare encephalitis is that clinicians look to each other to educate, and there's a lot of these encephalitis conversations that take place at both infectious disease and neurology conferences. And then just the general public so that we can raise awareness so that when someone is having symptoms that may lead to encephalitis, that we can get to a quicker diagnosis. We have several major initiatives, part of it being to enhance the medical provider education, also connecting survivors and caregivers to qualified providers, people that understand it, and just help the understanding overall when people are in the throes of the illness, trying to learn so much about this word encephalitis, which is big to them because they've never heard of it before, and also in the chronic phase where they're facing different challenges and need to understand what types of treatments and therapies are available. So thank you for joining. Part of this is our series for a World Encephalitis Day series of events. We have several webcasts that we hope you'll join us for. Some about the patient-doctor experience, also survivors talking about their own experience, caregivers talking about how they take care of themselves while taking care of others, as well as several others. So thanks for joining us again. Carol and Karen, I'm going to turn it over to you, and I know you'll have kind of a different perspective since one of you focuses more on adults and one more on children, but in its basic sense, can you, in your own layman's terms, explain what encephalitis is? Karen, I'll start with you.
Thanks, Becky. So if you'd asked me that question a decade ago, I would have said encephalitis is infection of the brain tissue. But what's become increasingly apparent is that it's not just infection. There are a number of non-infectious or inflammatory conditions that can also cause encephalitis. One of the challenges, though, is we don't have good access to brain tissue to make the diagnosis. So if somebody has pneumonia, we can often get tissue from the lungs, or if somebody has an infection of the skin, we can do biopsies. But getting to the brain tissue itself is really quite tricky. And so we really rely on a number of different suggestive findings, and those can be signs or symptoms that a patient may have. They can be laboratory tests. They can be radiology tests. But it's really a complicated algorithm to try and identify patients with inflammation of the brain.
Great. Anything to add to that, Carol?
Yeah, well, I would say with children, similar to adults, when they present with encephalitis, there's, often some sort of change in their behavior. And, it can be almost any kind of change. It may be that they're suddenly sleeping a lot more. It could be that they're acting incredibly strangely. They're saying funny things or almost hallucinating. But unfortunately, there's not one single thing that makes that defining clinical sign or symptoms that where we know it's encephalitis.
Although Carol raises a really good point, and that is sort of the one sort of unifying symptom that all patients have is some kind of alteration in their thinking. So I think that is one very general characteristic that we look for in patients when we're concerned about encephalitis.
Yeah, and Karen, I think that was important to point out, even though it's everyone with encephalitis should have, before you even contemplate somebody having encephalitis, we really are looking for some major change in their behavior or level of consciousness. But it's important to realize there's lots of other things that can also do that. So that confounds making that diagnosis up front.
Interesting. Thank you. So, there's so many things that I've heard you talk about in the past about what makes encephalitis so complex. You've talked about there's so many different causes or etiologies. That there's no standard treatment protocols. I guess in your own words, how would you factor that in? And Carol, I'll start with you this time.
Well, so I think, to point out that, we just got through saying how hard it is to even recognize for sure that somebody has encephalitis. And even though, I think a lot of people think, now with modern medicine, we have so many great tools available to us. And it is true. We have much better tools today than we did 40, 50 years ago. But, we don't generally have brain tissue, which is ultimately what you'd really need in most cases. So we use other tools like spinal taps and the spinal fluid which is basically the fluid that the brain is bathed in. We use that as a proxy and that helps us make the diagnosis. There's very sophisticated neuroimaging like MRIs that we have available, and that might be helpful. But surprisingly, a lot of our patients with encephalitis have normal imaging. And so, again, it really is difficult to make a diagnosis in a lot of these cases, a definitive diagnosis.
Okay. Karen, anything you want to add to that?
Yeah, no, I think it is a complex syndrome, and I think that sort of hits the nail on the head. It's a syndrome, and what patients often are asking me is, well, what particular cause do I have? Because it makes a difference. If we're able to identify a particular infection, then we're often able to target treatment towards that particular organism. We often have more data in terms of what the outcome in general for a particular infectious etiology. And I think one thing that's so frustrating, certainly to patients and family members, but also to the physicians, is that is not universally the case, that in a lot of situations we're able to identify a syndrome of encephalitis but not be able to identify the cause. Or conversely, we are able to identify a cause, but it may be, days to weeks after the acute illness. And I do think that makes it harder both for the treating physician as well as for the patient.
And I'll just add, the fact that we've talked about all the difficulties, but if you were to look in a textbook of encephalitis, and any major medicine textbook, what you see is you'll see literally hundreds of different causes outlined. And so it's very hard for physicians to know where to begin on some of these cases, because there's really just a huge, what I call a laundry list of all the different possibilities.
One thing that I think Carol took the lead on several years ago, but I really think has helped sort of globally in terms of classifying encephalitis, is determining a case definition. And I think we recognize as researchers in the field that what one group might be calling encephalitis was not the same as a second group, and it was sort of comparing apples and oranges in terms of output, and that, I think, translated into recognizing this in individual patients as well. And so I think one thing that has sort of moved the field forward is having a standardized case definition that includes, again, a number of different variables, but at least what one individual might be calling encephalitis is the same as another individual, and it makes it a little bit easier to standardize what the syndrome is.
Okay, thank you. Let's see. There's, as we've discussed already, just so many different causes of encephalitis. And, you know, on the slide that we've all prepared here, it shows that more than 50% is unknown. It must make it very frustrating when it's in the diagnostic phase to try to assess how to treat somebody if you don't know the cause. So I guess part of the question is, you know, why are there so many unknown causes? And then the other is, with these different types that we do know about, whether it's a virus, an infectious disease, or perhaps an autoimmune disorder, how do you distinguish them, and what are the complexities in determining each of these types of causes?
Well, I'm going to jump in because I want to take the easier question, which is the second one, and I'll leave the harder one for Carol. You know, I often will try and educate folks, medical students or residents or fellows, that although there are a huge number of etiologies, just by sort of getting a really complete and thorough history and searching for some of these exposures really helps, I think, in terms of narrowing that list. And so, as Carol said, there's a laundry list, and if you checked off every single box on that laundry list, you'd go through a lot of spinal fluid and a lot of blood on patients without necessarily finding an answer. And so I think being very discriminating and thoughtful and purposeful in terms of what are the likely things based on time of year, exposure to animals, the clinical findings. So I think this is really a great example of an infection where getting that very thorough history to sort of tease out particular risk factors is really, really key.
And along those lines, you know, as far as I agree with you, Karen, even though I mentioned there's just this incredible list of possibilities, when it comes down to it, there's really, after you've done a really good thorough history about exposures and even the clinical manifestations, you can often, you know, narrow that list. But in addition to, you know, remembering what the key things to look for is, it's knowing what test to send as well. I mean, in a lot of cases that we dealt with, the physicians were thinking of the right diagnosis, they just didn't send quite the right test. And, you know, for instance, West Nile is a good example where a lot of people thought, oh, these new molecular tests will be the best test to send for West Nile, and yet it isn't. And so I think there's so much about the diagnosis that even if you've considered the right particular infection or the right etiology or cause, it's really important that the physician send the right tests and at the right time of the illness.
That's a great point. And I also clarify, I think, you know, we can sometimes throw our hands up and say, well, there's so much to look at, where do I focus? But I think there's some diseases that we would recommend that any patient with a putative diagnosis of encephalitis get tested for. And that's based on either the fact that they're very, very frequent or that they have a very effective therapeutic agent to treat them with. And so at least in the adult population, we would recommend that anybody presenting with encephalitis get treated for herpes simplex virus, or excuse me, not treated, evaluated for herpes simplex virus, be evaluated for the virus that causes chickenpox, which is varicella zoster, and certainly thinking about other things such as West Nile during appropriate times of year, tick-borne infections, which can be bacterial or viral, and in the bacterial subset are very, very treatable, or even diseases like syphilis that have great antibiotics to treat them with.
Yeah, and Karen, our list in pediatrics is not so different. I think one of the things that would differ from adults, though, is we have a lot of enteroviruses causing encephalitis in kids. And so that's kind of goes to the top of our list. And unfortunately, we don't have a therapeutic agent to treat it with, but at least by identifying it, that can be helpful. Like adults, herpes is always on that list, and because there's a treatment, we not only, want it tested once, but we often recommend testing again just in case you missed it in that first pass. With pediatrics, we don't see nearly the same number of West Nile cases as you do in adults, but certainly it is a cause. Yet there are certain arboviruses that we see more commonly in kids than you do in adults. And I think in your part of the country, you see more of these than we do in where I live, and things like lacrosse virus.
Yeah, that's true. That's true. And it's interesting because I am based in central Tennessee, and it is not spread uniformly across the state. We have really sort of these microenvironments where they have fairly high rates of lacrosse infections in the eastern part of the state, particularly near the Smokies. And as you go in sort of concentric circles outside that area, the rates go down. So I think it's sort of brings to mind another thing that I often will mention when I'm teaching about encephalitis, which is, think locally. Think about what's in your environment, or if the patient has traveled, what's in the environment where they might have been in, because there's no sort of, rubber stamp for what you might find throughout the United States.
Yeah. And really, on one hand, when I talk about encephalitis, I often talk to people about finding those treatable things like the herpes or the varicellas, and even the autoimmune that we haven't really talked about that we should touch on in a minute. But I think it's important, though, families really want answers. And so if you don't get some of those tests up front, you may lose that opportunity to find it. So even if it's something that's not treatable, I still think it's important to find out because these patients are often critically ill, and when you don't know what it is, it's very hard to manage.
And that's a good point. I sometimes get really locked in on what I do as a clinician, but these are bigger issues than that. I think there are public health ramifications of some of these illnesses, and I think a great example is rabies. So, for instance, you could argue back and forth whether rabies is treatable or not. That's somewhat debatable, but in general, it's not a treatable infection. However, it's important to identify for animal control reasons. It's important to identify because there's prophylactic vaccines that can be given to folks who may have had close exposure. So I think that's a good example of getting an answer, not because we necessarily have treatment for the particular organism, but because there's sort of a bigger picture to look into.
And Carol, you mentioned enteroviruses, especially affecting children more than adults, at least in the area where you're in. Can you help the layperson understand what an enterovirus is?
Sure. So enterovirus, there's a whole group of viruses. There's about 70 different enteroviruses. Very, very common childhood illness. I mean, all children are going to experience at least a handful of enteroviruses as they grow up, when they're at daycare, when they're in preschool, in kindergarten, and so on and so forth. One of the causes that many people may be familiar with is something called hand, foot, and mouth disease. That is caused by a couple different enteroviruses. And for reasons we don't understand, in a very small subset of children, they may have a whole school that gets hand, foot, and mouth disease and gets, bad virus for a few days. But one of those children may end up getting the encephalitis. And so we don't understand why, we take a relatively common virus and we get a rare manifestation of it. So, but we know this, that this happens, on a fairly frequent basis. I mean, encephalitis is rare, but once you start thinking about encephalitis, enteroviruses are common within the pediatric population. And just to digress for a minute, if people have been watching the news over the last couple of years, we've had this polio-like illness, spreading the country that seems to come every 2 years. And that indeed is thought to be due to an enterovirus. Very unexpected, but, very devastating illness. And that is of a polio-like illness where the infection is in the spinal cord, it's really almost like a type of encephalitis. It's just, rather than being in the brain itself, it's in the spinal cord. Very similar, what we call pathophysiology, where the virus gets in where you don't want it to be and causes inflammation, and then has, pretty bad consequences.
I'm thinking about your example of the enteroviruses in pediatrics, and it reminds me of the situation in adults with herpes simplex virus. The same virus that causes encephalitis is the one that causes fever blisters. And if you look at adults, I mean, the vast majority of adults have been exposed to that virus. And so it's a bit of a mystery why such a very, very small percentage of folks develop brain infections with this very common virus. And I think we're sort of just beginning to scratch the surface of understanding that, but there's some studies that have looked at families where there are multiple members who have developed herpes simplex encephalitis and found that there's some subtle defects in the immune system that make particular individuals more at risk for this. And so I think that our understanding of this syndrome is really going to increase in the future when we learn more about the genetic basis for risk of particular organisms.
Yeah, and Karen, just sort of to take that point a step further, you know, when both you and I started these unexplained encephalitis projects many years ago, I think we both thought, oh, we're going to find all these new novel kind of pathogens, you know, where there's going to be things that weren't discovered, but we actually found very few novel pathogens. And I think what we found more and more is that a lot of our cases were caused by, when we did find an answer, were caused by a relatively common virus, whether it was enterovirus or herpes virus or chickenpox virus, and yet it was causing an unusual manifestation. So I think when we sort of swing back and talk about encephalitis overall, a lot of the causes are of things that are just out there, we're all exposed to, but for some reason, in some very small percent of our population, thank goodness it's small percent, are affected in an odd way, and we really need to understand that.
You know, Becky, you had asked initially when we got to this slide about why so many unknowns, and I don't have a real answer for that, but I think one thing that is not necessarily apparent looking at this, when Carol and I started our studies back, I'm trying to think, in 2000, autoimmune disorders really were not on anybody's radar as an important cause of encephalitis. And so at least some proportion of the unknowns back then were packed with patients who had some of these diseases that really didn't have a name to them yet. And over the last decade to 2 decades, there's been tremendous progress in terms of identifying antibodies that attack that attack the brain and cause a syndrome of encephalitis.
Yeah, there's been a lot
and
of
that. Go ahead.
Yeah, go ahead, Carol.
Well, I want to just add to what Karen said. It really has been literally an explosion of those cases, and I think you know, within the Encephalitis Project, we were working with Dr. Dalmo, who is really the person that's described and been at the forefront of describing things like the anti-NMDAR encephalitis. And we were shocked to find how many of our cases were testing positive. And indeed, in a certain population, it was actually more common to find that than it was to find some of our other relatively common causes of encephalitis. So that area has really just actually absolutely exploded as far as our knowledge and the detection. And those cases are particularly important to sort out because the treatment for an autoimmune type of encephalitis is vastly different than the way we would treat somebody with herpes or with enterovirus.
Yeah, thankfully that you know, those studies have helped diagnose patients faster and more accurately. We've certainly seen a change in the landscape from just 5 years ago when we were hosting meetings to just the last 6 to 18 months, where it used to be predominantly people with herpes simplex encephalitis or perhaps West Nile, and now the attendees, more and more of them have those autoimmune disorders. So we're grateful for what the medical community is doing to identify more causes. I'm going to move to our next slide that kind of just talks about West Nile in particular, and how an environmental alteration can change the landscape of encephalitis. So 20 or so years ago, we weren't even aware of West Nile in the US because it had not impacted us. I know it kind of came up from either South or Central America and entered the US in a way that has certainly created an epidemic in several years, especially in 2012, where I am in Texas. We saw so many cases, and it was amazing of how many didn't just have the flu-like symptoms, but actually had the neuroinvasive type, encephalitis type of West Nile. But I just wondered if you had any other comments about that. It certainly has impacted a lot of costs, both in hospitals and just, overall treatment, but also the number of people that have been impacted is just amazing.
This is Karen. This is a great example when Carol had mentioned that we thought that we were going to find a bunch of new or previously unheard of viruses causing that 50% of undiagnosed encephalitis. A lot of that optimism was driven by West Nile, because this was a disease that the vast majority of even infectious disease experts in the United States had never heard of before 1999. I think this is a really interesting disease. It's a testament to a really astute clinician who noticed sort of a cluster of adults at her hospital, all of whom lived in a fairly small geographic area, who are coming in with encephalitis. And it's not uncommon to see a sporadic case of encephalitis every once in a while. But when she saw, 3, 4, 5 elderly folks who all lived within several miles of each other, I think the bells went off in her head, and she sort of raised the alarm and got the public health folks involved, and I think the story sort of moved on from there. But to me, this is an example of a disease that has emerged over the last couple decades and really become endemic in our healthcare system.
Yeah, we see a lot of activity, especially from people recovering from West Nile. They seem to have more of the fatigue and mobility issues and migraines, even after 4, 5, 6 years. So they certainly have been quite vocal. So as we look at, we've talked about already about how complex encephalitis is, but it's also complicated in that everyone presents so differently. There's, often, some people might have 3 symptoms, some might have 10, but it's just interesting that, every case does present very differently. Maybe you can speak to, the imaging that you alluded to earlier. Things have advanced, but, we still need more advancement in that area, and research that needs to be done, et cetera. But any comments on, the further complication of encephalitis? Carol, I'll point to you first.
Okay, so as far as the complications or just the presentation?
I would say, as we talk about, the imaging not being conclusive, sometimes,
Sure.
Why is that? I've heard you talk about how somebody could have a pretty severe case, yet their MRI is actually not detecting anything. That's pretty mind-boggling for those of us on the layman's side of the world.
Yeah. And in fact, thinking back over our data on the California Encephalitis Project, which was actually several thousand cases, about 50% of our cases or more had a normal neuroimaging at the onset, it is mind-boggling. And there were cases that were seizing, we had a subset of cases that had such bad seizures they had to be put in a phenobarb coma. And I don't mean an hour seizure, I mean seizures days on end. And we were amazed with those cases that early on, those MRIs were often normal. And just like the lumbar punctures, you can do a lumbar puncture and not necessarily see lots of white cells or lots of signs of inflammation in that fluid. So it really is astounding, that you can have somebody who's so profoundly ill and yet we're not able to actually, see anything on neuroimaging. And what we keep saying is what we ultimately need is brain tissue, but we know that that's extremely neuroinvasive, and we're not suggesting it. It's just that's we have a lot of limitations on our diagnostics.
I think that sort of points out too, if you don't look for it, you won't find it. And so I think one of the limitations is not just the types of tests we have available, but that the clinician is sort of responsible for deciding, is that something I need to think about? If so, how do I best test for it? Where in the course of the illness is this patient? What is the best sample at this time? What is the best laboratory to send that test to? So there are a lot of sort of variables that go into each of these different decisions about what might be causing encephalitis.
Okay, and then we have here a whole host of symptoms that a lot of people experience at the onset. Could be migraine and fever and joint pain. Both of you have mentioned seizures. There's such a wide variety. At what point does a doctor start to think about encephalitis as a possibility when the symptoms can be so varied?
I think, we both have alluded to this, but I think once there's a profound change in their behavior and if they're acting extremely bizarrely, like or they don't know what day it is, or they don't know what year it is, or the family will describe a very profound change in behavior, that is when we start thinking of encephalitis. Alternatively, it could be that they're suddenly, they're just sleeping, 20 hours a day. But the problem with that is there's lots of other things like just, that could also cause that aren't encephalitis.
It definitely speaks to how difficult it must be to diagnose. Karen, did you want to add anything?
Well, I think from the symptoms, there's just a tremendous number, just as Carol said. I think one thing that's very helpful in honing in is getting spinal fluid. And although we don't uniformly see abnormalities in spinal fluid, they're very, very frequent, and they certainly would sort of direct the clinician to thinking about, is there a central nervous system process going on? Sometimes the findings might be nonspecific. They may not help us decide if someone has meningitis, which is just infection of the lining of the brain, from encephalitis, which is infection of the brain itself. And they're non-infectious things that can mimic, and things like strokes or bleeding can again show abnormalities. But I think having the symptoms sort of trigger the provider to go the next step, which might be doing a brain x-ray like an MRI or CT scan, and then obtaining spinal fluid, helps to sort of bring the picture together of encephalitis.
And then, also, the presence or absence of fever can also be very helpful. When there's a fever present, we often think it's more likely to be infection, but we know that certainly isn't always the case. And absence of the fever does not mean it isn't either.
Okay. Oh, we just had a question come in from Ohio. Somebody is asking, they see the slide now that says the symptoms at onset, one of them being light and sound sensitivity. And they're saying that, it's been 7 years and they still are battling the light and sound sensitivity. Is this normal? I think there's probably no such thing as, quote, normal for any particular case, since each individual is so unique. But I would say that it's not unheard of that somebody would have a continued issue that was presenting at the onset and continues to be problematic over years, not knowing whether it will ever go away or not. But there's certainly things that they could do to handle those. Any advice that you have for somebody that has those ongoing issues?
This is Karen. We talk about in medicine something called brain plasticity, which sounds really complicated, but just says that the brain is an amazing organ and it can really reconstitute itself in amazing ways. And so one thing we found through our study is that folks who are very, very ill at presentation, particularly if they were young and in good health to start out with, made, in some cases, amazing recoveries. And so I think that's important and challenging, because we really can't predict with great certainty who is going to make a complete recovery, who is going to have some residual, and how profound those residual complications are going to be. And so I think you, Becky, probably know better than anybody that folks who, to the outside world look like they've completely recovered may have some mild or what would be considered mild by other people, deficits that are left over from their illness.
Right, definitely. We had another question come in, I guess on a similar note. This person's in Washington. They said that they've always been very active. They've enjoyed hiking and bicycling, etc. And they can feel good for about a month, and then they go back to their activities of what they were, quote, before. But then the fatigue sets in, and they feel like they are having a relapse or setback. And the question is that normal? But also, is there a difference between a relapse and a setback? Carol, do you mind answering that one?
You know, I have to say, since I deal primarily with the pediatric population, we see most of our kids that once they recover, as far as I know, they tend to do quite well. So I'm not that familiar with any relapses per se. So I'm going to actually have Karen take that one.
Okay, Karen, balls over to you.
So I think it's just a difference in nomenclature. To me, a relapse is recurrent if it's infection, to start out with recurrent infection. If it's autoimmune, recurrence of the specific antibody sort of attacking the brain. And so while those do occur in the adult population, they're pretty uncommon in the infectious subset. And I think a lot of what you're describing is more of a setback. It's not uncommon for folks who've had severe illnesses, whether it's, encephalitis or, very severe pneumonia or any other really critical illness to have slow recovery and to have days when they're able to do a lot more and days when they're able to do a lot less. And what I tell my folks, regardless of what the type of infection is listen to your body. If you're feeling good and want to push yourself a little bit, that's great. You may pay for it the next day or the next week. But if you're feeling tired and fatigued and it's not a good day, your body's telling you it's a little too much.
Thanks, Karen. We have another question from Louisiana. Somebody's asking, how long does it take to recover? They had encephalitis 4 years ago, and they heard a rumor that you cannot get better after the 2-year mark. I guess I'll take a first stab at this, and happy for both of you or either of you to expand. But I would say that there is no such thing as a 2-year mark. Everybody is very different. Some people are going to have some residuals that stay with them for a lifetime. Some are going to have some that, to Karen's point about brain plasticity, that they're either able to use different therapies or treatments to help them overcome those and get them back to their baseline, or come up with ways to work around them. And there's always different ways to tackle some of the different things. But I certainly have seen people take the different courses like CogMed or Lumosity, and we don't endorse any particular program, but those are a couple that we're familiar with that challenge people in new ways, and it makes the brain think in a different way. And so, and some of these have been 7-8 years after encephalitis, so that really changes that 2-year mark to something that I personally don't believe in, because I've seen people improve even after 40 years later, some remarkable stories. So I guess I would say that that's definitely a myth. But anything that either one of you would want to add to that?
Just that I think this is an area where I think you and some of the other survivors I've met through Encephalitis 411 have taught me that we really don't know a lot about, and that increasing research and increasing involvement by physicians who specialize in recovery is going to be really important in terms of defining what recovery looks like and how long it can last for.
Okay. We just got another question in from Idaho. This person says that they live in a rural area where access to clinicians that know about encephalitis has been very difficult for them. Do you have any advice for people that live in areas where getting to a knowledgeable physician might be hours or maybe even a flight away?
Well, I would say that if they're critically ill, they should be at what we call a tertiary care center, where they're going to have the expertise of the neurologist, the infectious disease physician, the rehab people. This, as we've said many times, this is a very complicated syndrome, and I think early on you need to benefit from all the great diagnostics that'll be available, but these are complicated cases, and the more brains you can have thinking about a given case, the better.
Okay.
I would also mention, you know, I think in the acute illness, Carol's exactly right, that this is a multidisciplinary approach that will be most important. As people recover, I think one thing that may be useful to keep in mind is having a expert at a facility who can sort of talk to the doctors locally. Not every treatment or not every blood draw needs to be done at a tertiary care facility. So if there's somebody who can serve sort of as the person who is making recommendations, often these can be carried out by the local physician. So I think there can be, again, a team approach to support the patient who may not live in an area where there's a lot of expertise.
Great, that's good advice. Thank you. We have time for just a couple more. There's somebody from Florida who just commented and said that while they got great treatment in the beginning, the doctor says that, you know, you're not, quote, sick anymore. You know, it's time to just move on with life. And they feel kind of dismissed. What things can you help a person in that scenario that has kind of what I guess some of us would call the invisible illness, be able to get more care, better care? What words or phrases or scenarios should they be providing to their doctors to help them understand that life is still more challenging than they may appear on the outside?
Well, I think, you know, we've as a group have talked about that we don't have great outlines for rehab, or we haven't until recently, but I think people need to think about encephalitis more like not just a simple acute illness that's going to be here on Monday and gone the following week, but maybe something like we think about brain trauma. We don't think somebody that has, you know, brain trauma is necessarily is just going to go away in a week. And so I think we really all have to reshape our thinking that it often is more of a chronic problem.
Absolutely. Yeah, we hear that quite a bit. Okay, we're just going to finalize with one last call from somebody calling in from New York. They said that they feel angry and agitated all the time, but they complain that their families really don't understand. I think that kind of feeds back to what you were just talking about, Carol. And I guess it's why we want to reach the caregivers as well, is helping them understand not just how to take care of their loved one, but how to understand and empathize with the changes they're going through. You know, often if there's that anger and agitation, it may be underlying other issues that they just can't express because they don't know what they don't know yet. Or it might be that they maybe had some frontal lobe damage, and that is something that's maybe altered their personality slightly. But any advice to, I guess, patients themselves, as well as the caregivers that are in this new environment, where they recognize that, okay, there is change and we have to embrace that. But, you know, having to deal with the ongoing anger because, or agitation because the family doesn't understand can certainly be problematic in the relationships themselves. Any other advice on those matters as we close here?
Yeah, this is a circumstance that I think would benefit from talking to the patient's physician about. Some of these folks are started on new medications, and in particular on medicines to help with seizures if that was a problem during the acute illness. And sometimes we'll see side effects of these new drugs causing some of these symptoms. So I think a lot of times patients blame themselves, or family members think that the illness may have caused a particular set of sequelae. And while that may be true, I think just asking for medical advice about whether it could be a side effect from a drug or a medication that was prescribed for the illness is important.
Okay, great. Carol, anything to add to that before we wrap?
No, I think that's about it. Okay.
Well, Karen, Carol, y'all have always been a wealth of information, and you've certainly helped people today to understand all this. Thanks for answering their questions as well as going through our prepared material. If anyone has any additional questions, you know, feel free to reach out to us on our Facebook page, or submit a form or contact us at encephalitis411.org. And we appreciate your participation today. Thank you so much.